thank you for listening. This podcast is on urogenital atrophy, which affects lots of women, is underdiagnosed and undertreated. So it's a really important area to focus on, particularly for practice nurses who are seeing lots of patients for smear tests who may be affected, and it's an ideal opportunity. Any questions, please direct them to the paulabriggspodcast@gmail.com. I'm going to talk about urogenital atrophy, a condition which affects up to 80% of menopausal women, but very few of them will come and ask for help, partly because usually there is between 3 and 5 years between becoming menopausal and the symptoms starting, and the commonest signs are vaginal dryness and pain during sexual intercourse. So just waiting for this slide to change. So I suppose from a primary care perspective, and this is probably most relevant for practice nurses who are doing smears, is to ask about symptoms of vaginal dryness and pain during sex. Now, lots of women will have those problems, and it doesn't necessarily mean that they have urogenital atrophy, but at least it's an opening to talk about what might be causing the problem. So the environment within the vagina is generally acidic, with lactic acid produced by the superficial cells, reducing vaginal pH. And what that does is it keeps the other vaginal commensal organisms at bay. So those are organisms like E. coli and Mobiluncus. All women have lots of different bacteria within their vagina, but it's really important that lactobacilli, which produce lactic acid from the glycogen, which is sloughed in the superficial cells, remains the dominant organism. And as soon as that is no longer the case, then women can start to experience symptoms, dryness, irritation, and all of that impacts on quality of life. It affects relationships, and because women don't necessarily feel comfortable to come and ask for help, it can be several years before the situation reaches such an extreme level that something triggers the referral. At one point in the menopause service, which I led recently, we surveyed the patients in the waiting room to see what the main symptom was that had brought them to the clinic, and I think we picked up something like 78% of women on that individual day of the survey were there because of sexual difficulties. Okay, just waiting again for the slide to change, which is probably not a bad thing. So as you see, year on year, vaginal dryness becomes more of an issue. So instead of the tissues being plump, well hydrated, having the ability to stretch, so tissue elasticity becomes affected by lack of estrogen. As you know, the vagina has rugae, folds, which allow the surface area to increase, which is obviously necessary if a woman's having sex or having a smear. And those folds go, the mucosa becomes much thinner, and the vagina becomes shorter. So you can see in this slide that with lack of estrogen, instead of the tissues being healthy, they're a healthy pink colour with the ability to stretch, everything becomes thinner, much more liable to trauma. So pain may be the presenting symptom, pain during sex, pain during passage of a speculum, but also bleeding. The entrance to the vagina becomes deficient. The urethra becomes much more prominent, and women will sometimes present with what looks like a urethral caruncle. So I suppose I'm coming on to the important point here that Again, history is incredibly important. Listen to the patient. If she's describing vaginal symptoms suggestive of vaginal atrophy, then examination is very important, because whilst this is a very common condition, there are other conditions with which it can be confused. It could be confused with HPV infection, or squamous cancer. Whilst cancer of the urogenital region is uncommon, it's something which you wouldn't want to miss. And then there are much less common conditions which need a very different form of treatment. Lichen sclerosis epitrophicus, again, is very common and very easily confused with urogenital atrophy. So just to continue to describe the findings on examination, you may note that the pubic hair is thinner, that the labia majora have less fat, so architecturally they look different. The labia minora can go all together. Due to severe atrophy, they may fuse superiorly over the clitoris, so that the clitoris may not be able to be seen any longer, or the clitoral hood can be retracted and the clitoris is then exposed, which can cause discomfort. And then, as I said before, the mucosa is thinner, and you can see in this slide here the characteristic changes that you would have on a vaginal smear. Instead of there being lots of superficial cells which will slough off, containing glycogen to produce lactic acid via the lactobacilli, you get an increase in the ratio of parabasal cells, so the cells at the bottom of the mucosa, and less superficial cells. And in addition to what's happening in the epithelium, in the connective tissue, again, you will have a reduction in connective tissue, a reduction in moisture, which is one of the reasons why laser therapy works well. And I'll go on to talk about that towards the end of this podcast. So what the patient may describe to you is dryness. That might be a problem during sex, but the patient may not be sexually active, and she still might have dryness, irritation, pain. Prolapse is more common because the urogenital tissue quality is important to support the genital organs. Postcoital bleeding is a very, very common presenting symptom, and these women will often end up in rapid access. They may have rigorous investigations, transvaginal ultrasound, which is very uncomfortable, outpatient hysteroscopy in theatre. And they may be diagnosed with urogenital atrophy, but many of these women are not treated. And I think there are so many different treatment options now, both non-hormonal and hormonal, that the history is important, the diagnosis is important, but so is treatment. And first-line treatment would normally be vaginal estrogens. Many women, as we discussed in the menopause podcast, are scared of hormones, or they're anxious about hormones. And those women may prefer to use vaginal moisturizers and lubricants, some of which are prescribable in general practice. And if this condition is not treated, year on year, it gets worse and worse generally. Very few women would it remain static. And it's certainly unlikely to get better. We know that continuing to be sexually active is actually beneficial, and that works a little bit like laser. So sex will cause microabrasions, and that stimulates fibrocytes to become fibroblasts again, and they create connective tissue. And then I think it's really important to remember to ask women about urinary symptoms. Is she mapping out where all the toilets are when she goes shopping? She might have overactive bladder, but she might have urogenital atrophy, or she might have both. Is she somebody who never had problems with urinary tract infections and all of a sudden these become a problem? So if you think about what you saw on the slide with an alteration in the ratio of superficial to parabasal cells, that's also happening in the bladder and in the urethra as well. And all of these will respond to treatment, and you can add the treatments together. So you may have a woman who doesn't respond quickly to vaginal estrogen, and that tends to be what happens. It can take 3 to 6 months of treatment, and many of the one of the treatments has a lifelong license. So that's estradiol 10 microgram tablets, which is very, very low dose, generally prescribed daily for 2 weeks and then twice weekly, and that should be indefinite. I see lots and lots of women who are restricted to 3 months of vaginal estrogen, and there's no reason for that. Women who have a diagnosis of breast cancer, unless they're using an aromatase inhibitor, may be eligible for vaginal estrogen therapy with lubricants and moisturizers. And there are other treatments which we're also going to talk about, because what we don't want is a treatable condition to have a negative effect on a woman's relationship, and that then affects her overall quality of life. This slide, which is taken from Revive, a large patient survey, shows that the vast majority of women present with dryness, and many of those, the ones who are sexually active, will also have pain during sexual intercourse. So the British Menopause Society guideline has recommended using the lowest dose of vaginal estrogen to treat vaginal atrophy. However, having said that, just remember that for many women, 10 micrograms of estradiol delivered vaginally twice a week is not enough. For women who are using HRT, who have a progestogen as part of their systemic HRT, they have endometrial protection, and therefore it would be reasonable to use vaginal estrogen more frequently out of product license, but we do that not uncommonly in medicine. So the reasons why I think women don't come forward for treatment are, one, they often get told it's something else. I've spoken to lots of patients who've been told that they have thrush, when in fact they don't. They have an alteration in their vaginal flora as a result of lack of estrogen. And when the vaginal bacterial flora changes and there is an overgrowth, say, of E. coli, that's much more likely to cause a UTI, particularly when you think about the urethra becoming much more prominent, more exposed, more prone to infection, and the bacteria are sitting there. So they might not understand what's going on. They might come to see somebody who doesn't recognize what the problem might be. They might be anxious about vaginal estrogen therapy, which is in fact very, very safe. The clinician they see could theoretically be anxious about adding a vaginal product to a systemic product, which again is actually probably less of an issue. As I said in the menopause podcast, a very small amount of estrogen delivered vaginally is absorbed. It's much more likely when treatment is initiated. And many women discontinue treatment because they feel it doesn't make the sort of difference that they're looking for. So your support, your encouragement for them to continue is important. And I think I wouldn't change necessarily in the first 6 months unless somebody was very unhappy or they had other side effects. And some women will develop nausea. So these are the treatment choices. We've talked a little bit about vaginal estrogens. We have products which contain estradiol. And then there are some other products which contain estriol, which is weaker and therefore less likely to be any sort of issue when we consider concerns about systemic absorption. Ospemifene I mentioned in the menopause podcast. It is a selective estrogen receptor modulator, and it's not appropriate for women who are on HRT. It has a beneficial effect on vaginal tissue quality, but doesn't have any significant impact on breast tissue or the risk of VTE. It's an oral treatment, 60 milligrams once daily, So it's particularly good for those women who are very severely affected. Now, I've seen women who struggle to walk, who can't exercise, who can't sleep at night because of intense symptoms associated with urogenital atrophy. And then we have the non-hormonal treatments. Now, you could argue that dehydroepiandrosterone is in fact a hormone, and it probably should be considered as that. It is marketed as an intrarosa. It's converted via a process called intrachronology within the vaginal mucosa into estrogen and testosterone. And we do know from research that's been done that testosterone is very important for maintaining urogenital tissue architecture. We have no testosterone for topical application in this country. And so that would be the only option for women for whom vaginal estrogen therapy after a 6-month trial of an increased dose didn't appear to be working. It is delivered as pessary, 6.5 milligrams, delivered vaginally on a daily basis. And I think it's useful now just to talk. Oh, we also have an estradiol ring, 7.5 milligrams of estradiol delivered daily via a ring which is inserted every 3 months with a license to be used for up to 2 years. But in women who maintain a thin endometrium, that can be used for longer. You wouldn't normally investigate or assess the endometrium using ultrasound unless a woman was bleeding in association with use of vaginal products. But for this, for maintenance with the estradiol ring, it is helpful. And finally, laser. There are 2 types of laser, CO2 laser and erbium YAG laser. My personal experience is with CO2 laser. It's intense. It's delivered via a stacking system, so the women require anywhere between 3 and 5 treatments at the outset. Each treatment is delivered between 4 and 6 weeks from the last, no longer than that, because if she waits longer, she has to go back to the beginning. So the first treatment treats one level, the next treatment treats to a deeper level, and the third treatment a deeper level again. Most of the vaginal tissue is unaffected by the laser, so that means that the treatment is not particularly uncomfortable because only a very small amount of tissue is damaged. CO2 laser is intense, but the treatment, in fact, is fairly rapid. The vaginal treatment can be delivered in less than 5 minutes, and vulval treatment uses a DOT technology, so again leaving lots of good healthy tissue to speed up recovery, and that's delivered often in association with the vaginal treatment. The vaginal treatment very rarely requires any form of anaesthetic, whereas the vulval treatment can be uncomfortable, and personally I would recommend that women have lidocaine ointment applied or something similar to reduce discomfort. So the laser is attracted to residual water, and again it stimulates those dormant fibroblasts, and they then start to create connective tissue again. It's a very good treatment for lichen sclerosis, but as yet there have been very few randomized controlled trials, none in this country, and that's desperately needed. And I think the other thing about urogenital atrophy is, as I've said during this podcast, the diagnosis is based on the history and examination, but there is no objective scoring system in current use which would allow a woman to be given a diagnosis which, if she saw 5 different people, would all come up with the same diagnosis. So there's lots and lots of things that need to be worked on to improve awareness, to ensure that women are aware of all treatment options, including the treatment options. Laser's expensive. That's the nature of that treatment, because the actual machines are expensive. But for women who've had breast cancer, and particularly for those women on aromatase inhibitors in whom it's not good practice to prescribe vaginal estrogen, but who may be young and they may be unable to have sex, I think opening the doors to some of the newer treatments are really important. So that's the end of today's podcast. Any questions can be directed to the paulabriggspodcast@gmail.com, and I look forward to you joining me again for the next podcast. So thanks for listening. I hope you found that useful. I think even if it made you think a little bit about the possibility of urogenital atrophy and the range of treatments, many of which are very safe and have the potential to make a massive difference to women, then that's a job done. Thank you for listening, and we'll see you again soon.